All right, we are back with another familiar face, Jordan Donnell, my bestie from I was gonna say the Westie. I'm like, wait, are you in the West Side? I can't never. Yeah. Okay, my bestie from the Westie. That
I
so
am in
works.
San Diego today.
That's so funny. My sister just got a new car, so I keep joking with her. I'm like, is that my bestie in a Tessie? It's not a Tesla, but just a newsflash, but it's still funny. Um, Anyways, hello, welcome back. We are talking with Jordan, and Jordan, you've been on the show so many times, so I feel like I don't need to like formally introduce you. However, I feel like when you've came on in the past, it was like you shared your personal story around right, like egg storage and I was gonna say egg secretion, egg storage and all that, and just like what a whirlwind of a time that was for you. We've talked more so in the role of like you being a sex coach. And so I think today is different. Like the audience gets to hear from you in a different light. It's like more medical, Jordan. And I reached out because right, we over the years we talk about hormones and how important it is to have hormones tested. And it's a constant conversation that I'm having with clients and I send them this list. And I'm like, this is a list that my friend Jordan has given me, and a little bit from thyroid, or yeah, like thyroid and like women's hormone paneling that I've done on my own. And then I feel like I send them this list and I tell them, I'm like, write it down on a post-it note, take it to your doctor's office, tell them these are the things that you want to be checked. But then I'm like, that's it. That's where it ends. Like I can't tell you why. I can't tell you what these things are, what it means when you get your results back, which we probably can't go into like what meaning deeply is on results. Like definitely talk with your doctor when they're around that. But I'm like, we need a podcast to where I can send them the list, listen to this podcast, and then they know, right? Because education is such an important part of this and hormones testing and all that.
Absolutely. And when you go to your provider and you're requesting test results, it will be a lot easier when you can say, this is why I want it tested,
Hmm. Hmm.
rather than, well, I saw this online. Somebody told me. When you come informed and um, having that support, it really helps you advocate for yourself.
Hmm. And you were such a huge part of that on my journey. You know, I remember, gosh, this was in 2021, right? Like I got off birth control and like things in my body started changing. I started noticing different things and being able to come to you again as a friend, as a colleague, as somebody that I trust in my life. You were so helpful for me. And I'll never forget going into my doctor's office and saying, hey, I want to have my hormones tested. And I'm like, I want you to do like a women's health panel on me, right? And I feel like I was still so naive even back then, but my doctor literally was like, what does that include? What does that involve? And I'm like, okay, so that to me was like, okay, I need to be better informed. Because at that time I was like, well, I know a few things, but I know there's so much more, and that's actually why I ended up going through Everlywell, which is a company that you can go, you can get the at-home testing. I know we've both had personal experiences with that, but then it was just it made it so easy, right? Like they had their women's hormone panel already set. I did the blood, I did the spit, sent it in, boom, I have my results. So we can get into that maybe a little bit more, but
Shameless
again,
plug for Everlywell.
yes, yes,
I've
shameless.
used them for my STI testing primarily myself.
Mm-hmm, mm-hmm. Yeah, I think I did the thyroid panel and the women's health panel through them, and more recently, even Danny, my husband, he's looking. They have a men's health panel too, that people can
Have you
do.
done
So,
the food allergies with them too? Because I feel like I know
oh,
some
that
people
was
have
the
done that
one.
too.
Yeah,
Hmm.
yeah, yeah. Actually, I don't think it was the thyroid one. I think it was the food sensitivity one that they offer. You're right. See, you just know me so well. Okay, so let's jump into this. We have the list, we have right, and we're gonna go through them one by one. Um, should I share the list just in general? So if people wanted, if they're listening right in the beginning, they can just jot this down real quick. These are the things that we're gonna talk about.
Sure, I think that sounds
Yeah,
great.
yeah, and then we can kind of go into this is why, this is
Yeah.
what it is.
And with the list, I'll just preface it with this that not all of these are needed for everyone. So
Mhm.
we're going to talk more specifically about kind of when that testing is done, what that's looking for, um, so that you can have a little bit better understanding. So just because we mention certain things, it doesn't mean that it's actually appropriate for you. And
Mhm.
again, Rachel said this, but talking to your provider, obviously, we advocate a lot for ourselves in healthcare, and we work with our clients a lot on advocating for ourselves. So this is really helping you advocate for yourself. And sometimes your provider may not know the rationale or know how to interpret some of these tests. Um, so they may not be able to guide you in the right direction with that.
Mhm.
But at the same time, talk with them about what is appropriate for you too.
Mhm. And keep asking. I think that's another important part there. It's like keep pushing. Or I've had several conversations with my doctor, right, on my own, going through my thyroid stuff and trying to get that figured out, trying to get a diagnosis, trying to figure out what if medication is right for me, all of that. And it's like it was many visits, many conversations with him around like this is what's going on, like and pushing, right? I need answers. I need you to understand me. It's not just about weight gain. I'm not just a woman here that's like, I want to lose weight, you know? It was so much more than that for me. And that just reminds me, right? Like women that are going to see doctors that are experiencing low desire. What are the answers that they're getting? Is it just have a glass of wine, get more relaxed, right? Things like that. And it's like, no, they're things like this, our conversation today, hormones can be such a part of perhaps why somebody is experiencing low desire, right? And the changes that our
Absolutely.
body naturally goes through.
Yeah. So yeah, let's
So
give them the list.
yeah, you could tell I'm close to ovulation because I feel fired up today talking
My
about
period's
this.
about to start. And so I definitely started spiking energy yesterday. And I'm like, my period's coming within the next 3 days. So I love how in
Yes.
tune we are with our bodies.
Yes. Same. Okay, so the list, and this is a list generally that I send to people, and then as Jordan said, we're not gonna dive deep into all of these. We might touch on some of them and then go into a little bit more depth on a few. So I have TPOAB. We have cortisol, which if you're having your cortisol tested, you need to have it tested morning, noon, and night. Cortisol is something that changes throughout the day from my knowledge. So to just have it pulled once, and that's why I liked that really well testing because it gave you, I had to do a blood, it was a blood or saliva, I don't remember, but I had to test 3 times in a day. So that it showed more accurately like when it was changing, when it was spiking, dropping, etc. So that's your cortisol. All right, then you have DHEAS. Yep, estradiol, FSH, free T3, free T4, LH, progesterone, testosterone, TSH, AMH, and prolactin are the those last two. Jordan's like, ooh, we need to add these. So I have my little notes here. So
Yes.
that's your list. And pause if you need to. Write those down on a post-it note. I would say obviously not if you're driving, but come back to this. Write those down on a post-it note, and then as you continue to listen to this episode, if you feel like some don't apply to or aren't in your wheelhouse, go ahead, cross them off your list. Highlight the ones that are extra important to you, and perhaps again like taking notes so you feel more knowledgeable going into your next appointment.
Yes. I love that. There was something you said at the beginning that I wanted to circle back to, but I totally forgot about what that was now. So let's just jump right into them.
Okay. Okay, which one do you want to start? Because when you were rattling
Ooh.
them off, I feel like you have a list in your head of like, okay, it's this. So,
Yeah. So I think we should kind of start with like reasons why we should do the testing,
mhm.
because I think that's where a lot of confusion is that often our complaints as women are dismissed. And low desire is a common one, depression or even mood stability. Some other things would be like no cycles. That is really where like my expertise is. So, like Rachel said at the beginning, I've been on the podcast millions of times, but I am a PA. I do primarily work in infertility. And so I have a lot of experience when it comes to women that don't have menstrual cycles or that are having irregular menstrual cycles, weird period things. That is my wheelhouse, so to speak. PCOS, like that's my wheelhouse. I love all that stuff. So, I think we should start with AMH and FSH
Mhm.
because those are really kind of a key for understanding our menstrual cycle. So we're going to start with the FSH, follicle stimulating hormone, and give you a little bit of background about this hormone. FSH is what is rising in our follicular phase that is being produced from the pituitary that sends a signal to our gonads, our ovaries, that says, hey, produce a follicle. And the higher that number is, the harder the body is working to produce a follicle.
Mm.
And so that is part of our menstrual cycle. That's the first part in leading to ovulation. So, FSH, follicle stimulating hormone, in my office, we like to see that less than 10. When it's greater than 10, that signifies that the body is working hard to produce a follicle, like I said. And then eventually, at a certain point, you're going to be closer to like 30s, 40s, 50s, and even into the hundreds. Generally, you're going to see that more in menopausal states. And so that number will rise over time. And once you hit menopause, which is 1 year without a menstrual cycle, and your FSH being like greater than about 30 or 40.
Okay, and so somebody that is researching, like, am I in perimenopause? That could be an indicator for them.
Yes.
Okay,
Yep.
helpful.
Yeah. And the other component of this is that FSH does vary throughout your menstrual cycle. So it's not going to be constant. It's going to ebb and flow based on what's happening in your body. And it does spike right before ovulation as well. But a true FSH is going to be right around cycle day 3. Our office, the office that I work for, we don't require doing it at cycle day 3. If it's high anywhere else, it's basically going to be high there. Sometimes, if a patient is ovulating and it's really high, I'll repeat it closer to cycle day 3 just to confirm. And, sometimes it comes back normal. Sometimes it still stays elevated. So, does vary throughout the menstrual cycle with that one.
And just for people, if they haven't listened to the back, when you say cycle day 3, at what phase, can you just tell us what that means?
Yes. So cycle day 3 is going to be your third day of full flow. So cycle day
Mhm.
1 is first day of full flow. And so then day 3 would be your third day after your menstrual cycles start.
Mhm. So somebody, if you were in menstruation, it's still okay to have hormone testing or blood samples done if you are in menstrual phase, if you're bleeding.
Yes. So most places are
Okay.
going to want to do them right around like day 3, 4, 5. That's going to be most optimal, but you don't have to do that.
Okay.
But technically, is going to probably be most optimal.
Interesting. I did not know that because generally when I do mine, right, like my office has blood drawn these days, and I never realized like it would be more helpful to line it up with where I'm at in the cycle. Hmm.
Well, in each of these labs that we're going to talk about today are different at different points.
Mm.
And so, we're going to get into progesterone, but the time that you check that is cycle day 21 if you have a 28-day cycle. So, again, like it varies. And
Hmm.
that it's not necessarily going to be one day where you go in to do all of your testing either.
Interesting. Okay. So this, yeah, it might be a multi-visit. Again, if you're someone that is wanting to really like take this avocation seriously, I would say.
Yeah. And it depends again on like what your goals are, what we're looking for. So there's
Mm.
there's so much more to it than it's not just cut and dry this or this. It's pretty gray, I guess you could say.
Yeah.
Yeah. So
Okay, so
then
FSH is helpful if, right, somebody is sort of seeking out, am I starting menopause? Am I in menopause? Anything else where, right, like relatable, somebody would want to have the FSH check specifically.
So FSH specifically, and this is where we'll get into our AMH as well, is with like
Mm.
low ovarian function or primary ovarian insufficiency,
Okay.
also known as diminished ovarian reserve. So FSH will rise at a younger age if we are experiencing that. So in my office, I see a handful of women who have elevated FSHs under the age of 35, which is not normal. Generally, you're going to see that rise more closer to 40 and even over 40 would be
Mm.
where you really would see that. Um, so, primary ovarian insufficiency is one of the things that you're looking for with FSH.
Yeah,
It's just saying,
great.
how hard is the body working? That's what it's
Hmm.
telling us.
Hmm.
And the other thing to add to this is like, we have to look at a full picture. It's
Yeah.
not just like one lab, this is a result. It's a complete picture of everything that gives you the information.
Hmm. Hmm. Okay. All right. Next on the list,
So,
which one we go into
yeah,
next?
we're going to go to the AMH because I think that's very similarly correlated. The AMH is called the anti-Müllerian hormone, and this looks at your ovarian reserve and ultimately how many follicles you have remaining, how many eggs you have left. And so this number, ideally, you like to see it greater than one. Oftentimes, if it's greater than six, it can be consistent with PCOS, which we're going to talk more about here a little bit too. But AMH is just looking at how many eggs do you have remaining. So, interesting fact, and we probably have talked about this before, but as women, we are born with the number of eggs that we have for our entire lifetime. And in utero, around about 6 months, we have about 3 million eggs. By the time we are born, we're down to about a million. And by the time we start menstruating, we're down to about 300,000. And each month, we are losing eggs. Whether or not you're on birth control does not prevent you from losing eggs. Some people are like, well, I spent 15 years on birth control. I wasn't ovulating. Your eggs are still diminishing.
Mhm.
So that
Even
is
real
looking at,
quick, even if they're on a birth control into which they do not bleed, are they still losing the eggs?
yep,
Oh, okay. Okay.
yep,
Continue.
yeah. I know. Isn't that interesting?
Yeah.
So with the AMH, if it is less than one, that would be considered diminished ovarian reserve. And so I see a lot of patients who have irregular cycles where they're starting to have some variation where that AMH starts dropping less than one, and then that FSH starts rising. And so that would be something to kind of keep in the back of your mind. With the AMH as well, this is important if you're looking at reproduction. So, if you are somebody who wants to have children, and depending on your timeline for that, this can be really helpful to guide you as far as your reproductive choices. And so, AMH really just tells you, like, what does the ovarian reserve look like? So, if it's less than one, you need to follow up with a reproductive endocrinologist if you are looking at having children in the future,
Mm.
just to be very blunt. Highly would recommend that. Highly would recommend considering egg freeze. Again, depending on a lot of factors, but age and fertility plans and what that looks like. But
Mhm.
I do see a lot of patients who have undetectable AMHs under the age of 35 who have that diminished ovarian reserve, who we're talking about egg donors with for reproductive needs because of the fact that um, they didn't seek or know about it in time to seek attention and medical treatment to preserve their fertility.
Mm. Okay. So, okay, yeah, and this is where it's like getting into you really want to see the bigger picture, and then it's again for people to have this list and okay, does this apply to me? Does this not apply to me? For someone that's perhaps not interested in getting pregnant, would do I need to still have this checked?
So, this is going to help give an overall picture of the ovarian function.
Okay.
So, I personally like this one for just seeing, like, what does that ovarian function look like, giving an idea because that number is going to decline over time. The rate is
Mhm.
unknown. There are some studies out there. I forget who sent me the study. I'd have to go back and find it. But for women over the age of 40, their time to menopause based on their AMH level. And
Mhm.
so it doesn't necessarily predict your menopause timeline, but the lower it gets, the closer you are to menopause.
Okay. We'll look back and see if I had that checked so I know.
Yeah, it's a very interesting one. Um,
Hmm.
I feel like you did have it check, and I feel like it was normal.
Okay.
Because I know I've looked through all of your labs,
All of my
but
things, you know,
I've
all of
I've
my
seen it
inner
all.
workings.
Oh yeah.
All right, awesome. So do we go into progesterone next? You mentioned that one a little bit ago.
Yeah, I think let's do like progesterone, LH, because that is still really focused on reproduction.
Okay.
So, LH, luteinizing hormone, to give you a backstory on this, this hormone spikes prior to ovulation. In the past, LH and FSH ratios have been used to diagnose PCOS. No longer is that considered really a diagnostic way of diagnosing PCOS. And so I see that a lot of times when I have patients who come in who are like, yeah, I ask them, how were you diagnosed with PCOS? Blood work, specifically FSH, LSH, FSH and LH ratio.
Mhm.
And again, not the greatest for diagnosing PCOS, but it is just one of those hormones that is often tested. I wouldn't necessarily actually get that one tested. It really doesn't give us a lot of insight. And I personally, we don't test it on our patients. I don't see a lot of added value in that one.
Okay. All
But
right.
again, depends on who you're seeing and what you're seeing them for. And if you're really looking at cycle optimization and working with like a functional medicine doctor, that may be really important to see, you know, what does that LH do? Do you have low levels of LH all of the time? Are you having a nice strong surge? Are you not? Because that can be tell us a lot about what's happening with your menstrual cycle. So again, so
hmm
many nuances to all of it.
hmm Yeah, and
The
it's
progesterone, oh yeah.
I was just gonna say it's like it's truly like figuring out what is going to apply to you.
Mhm. Yep. It's no cookie cutter.
Mhm.
Oh, going back to what you said in the beginning about, I remembered what it was about, asking your provider for like the women's health panel. And they're like, well, what
Mhm.
does that mean? For me, whenever I see a patient and they're requesting specifically, they're like, I want blood work. I want an endocrine panel. Okay, well, what does that mean to you? Like, what are you specifically looking for? So
Mhm.
that I can talk to you about each of those, what that information tells us, rather than just ordering what I think you're looking for. So for me, I always ask them, what does that mean to you? So that
Mhm.
I can understand where they're coming from, and maybe there's some additional things that I think we should add given
Mhm.
what they're coming to me for.
Yeah. Which is a great medical response to have from a doctor, a physician, right? Like that, yeah, that also very therapeutic of you to ask it then that way. What does that mean to you, right? Like, but again, yeah, you're actually showing the interest in like, I want to advocate, I want to be here for you, I want to give you the support and guidance that you're seeking. Versus, and that makes sense too. Now, just in this short amount that we've been talking too, of like what, right? Like you said, it's not a cookie cutter. It doesn't make sense to have like this is the women's health hormone panel, because
Mhm.
people do have different goals.
Yeah. So progesterone. Progesterone is one that I think is pretty tricky and pretty, mm, I don't want to say messy, but progesterone is a hormone that is highest in your luteal phase. And if you haven't listened to any of our episodes on the menstrual cycle, we've done some, I think, for yours and for mine, but
Mhm.
check them out. The luteal phase is when progesterone peaks. That is when implantation happens if you are attempting pregnancy. You need good progesterone support to support a pregnancy. Progesterone, again, varies throughout your cycle. If you have a 28-day cycle, typically you're going to check your progesterone on cycle day 21. If you have a 35-day cycle, checking your progesterone on cycle day 21 is going to be too early. So typically, a good progesterone check is about 7 days after ovulation to ensure that you have ample progesterone support in that luteal phase. Greater than 3 signifies ovulation. Greater than 5 is enough for, um, sorry, I got distracted. Great. I don't know why I got distracted because usually I'm totally fine. But anyway, greater than 5 is enough to support a pregnancy, but greater than 10 is most optimal to support a pregnancy. And so a lot of patients I see have their progesterone check cycle day 3 and they're like, "Oh, my functional medicine doctor told me that it's low." And I'm like, "Well, yeah, it's going to be low cycle day 3 because that's not when progesterone is being produced in the body." And so this one, I think, has a lot of confusion in medicine. I think we know, based on conversations that we've had, we know that there's a lot of confusion about women's hormones and women's health and how do we navigate all of that. And there is confusion within the medical community as well. So the other thing I would like to add about progesterone is that a lot of places will have you taking progesterone all of the time. Progesterone is primarily produced in that luteal phase. That's really when you would take it for attempting pregnancy. Progesterone only on its own all of the time is actually technically a birth control. There are progesterone only birth controls. And so, again, like it's looking at the whole picture. We'll beat that to a pulp by the end of this. But
Hmm.
with the progesterone, wild yam, don't take that every day. Okay. You haven't heard of wild yam?
No.
I'm surprised. It's a cream that is supposed to be a natural progesterone. And I have a lot of patients that are attempting pregnancy that are taking it all month. And I'm like, well, you can't. You can't do that. You don't want to do that. If you're going to take that, only take that after you have confirmed ovulation. Again, this episode is not medical advice, so please talk to your doctor. But if you're going to do it, that's what I would do is only take it after ovulation.
Hmm. Yeah. And so for somebody that is already in menopause, because this is a wait, no, their estro. I'm getting progesterone and estrogen mixed up. But for somebody that is in menopause, what what does progesterone look like for them? Does it
Yeah.
matter, right? Like is it
So,
is it applicable?
menopause is going to be a very different conversation when it comes to
Mm-hmm.
progesterone because that's going to not have, you're not ovulating. So, you're not going to have those peaks and valleys like you do
Mm-hmm.
with when you are ovulating. So,
Mm-hmm.
it's going to be pretty steady. It's very different taking progesterone menopausally versus taking progesterone while you are um, attempting to conceive or in your like your fertility days, your fertile days.
Okay. Yeah, and I think that's important because a lot of clients that I'm working with are going through menopause, in menopause, post-menopause. And so again, yeah, this is like listening to this and figuring out what's going to apply to you. And so I'm glad I asked that. Like,
Yeah.
yeah, and then moving forward, I think so far we did a good job with that, right? If somebody's in menopause, they're likely not planning pregnancy or wanting, to have pregnancy happen. So,
Yeah.
yeah.
And hormone management is very different for somebody menopausal.
Hmm.
And um, Dr. Lowe would be a really wonderful resource for especially people who are more like perimenopause, menopausal with hormones. She's definitely an expert on that and would probably be able to go into a little bit more detail about looking at menopausal hormones. The other thing that I wanted to add with the progesterone and in menopause, if you have a uterus, you cannot have unopposed estrogen. So you have to also be taking progesterone. And so that's where that kind of caveat of, this is not medical advice.
Hmm.
So being kind of cautious of what do you particularly need? And so for people who are menopausal, who are taking estrogen and have a uterus, they have to have the progesterone as well. Otherwise, it increases your risk of endometrial cancer,
Okay.
endometrial hyperplasia, the thickening of
Hmm.
the uterine lining.
Okay. Thank you, Jordan. I also want to, if in case no one's watching this, Jordan is sharing all of this, not because she's reading from notes or anything like this. Like this is all just things that she knows inside of her brain that she's talking about on a daily basis, and it just literally comes so naturally and fluently to her. And yeah, I know it's a lot to remember and to keep stored in your brain. So I just want to acknowledge you for that and thank you
Oh,
for.
thank you.
I know you help so many people each day with this stuff. So
Yeah.
yeah.
So, okay, we did FSH, AMH, progesterone, LH.
Hmm.
The other things that I think we should talk about next, prolactin.
Hmm.
So, prolactin is a hormone that is produced by our pituitary. And I think earlier when I said FSH, that's produced by not the pituitary. I got that one wrong. Um, hypothalamus. There we go.
Ah, okay.
FSH is produced by the hypothalamus. So I correct that error.
Correct.
Prolactin is produced by the pituitary. And prolactin is a hormone, a lot of times it is produced when we are breastfeeding that signals to the body, hey, we're breastfeeding, so we don't need to ovulate. And so when this level is elevated, it does have an impact as far as ovulations and can be a reason why people are having irregular cycles or no cycles. And
Mm.
so that can give us another insight as far as what's going on here. And that can be a really helpful tool. When this is elevated, I see a lot of patients for it being elevated
Mm.
because primary care doesn't know what to do with this. It's kind
Mm-hmm.
of one of those other weird ones. Like, what do we do with this? You're not breastfeeding, but you're elevated prolactin. It does have an impact as far as bone health.
Mm.
And so it's not one that I would ignore if it is abnormal.
Okay. Okay. And so somebody that is post-pregnancy, pregnant, right, this is going to look very different, or even menopausal, like this is going
Correct.
to look very different versus somebody that is not any of those things.
Yeah, exactly. So yeah, if you're breastfeeding, you expect it to be high. You're pregnant, it's probably going to be elevated as well.
Hmm.
So these are not ones that you would even test during that time, but
Hmm.
this is really for that lady that doesn't have a cycle or who has highly irregular cycles where you're like, what's going on with my body?
Hmm.
This could potentially be the reason. Not always is that the case, but it can contribute. It's
Hmm.
also an easy look when we're looking at reasons for infertility.
Hmm. And is there a ideal time of when to have that one tested?
Um, so this one is actually best going to be fasting.
Mm.
So in the morning, fasting, that's about it.
Okay.
Nothing as far as cycle day.
Okay. Cool.
Yeah.
Thank you.
Yeah. So, okay, the next one, TSH.
Hmm.
I think we
Hmm.
should do the thyroid panel, TSH, TPO, T3,
Hmm.
T4. So, TSH, thyroid stimulating hormone. This one is looking at, and I think you can talk a little bit about this one too, but this is looking at your thyroid and um, in particular, the TPO, the
Hmm.
thyroid peroxidase, thyroid, yeah, something like that,
That's
antibody.
the antibody. Yeah.
Mhm. That one is really looking for Hashimoto's or an autoimmune source of thyroid abnormalities. And so the TSH with the T3, T4 can be very tricky because there's this optimization, and then there is this other place of um, within normal, like depending on who you go see to evaluate your thyroid, they're going to say, oh, this is totally normal.
Hmm.
But you may not be optimized and you may not feel your best. And that's where I think thyroid gets really, really tricky because you have to look at the whole picture. But your thyroid, when you are not producing enough thyroid, not producing enough TSH, what that can lead to is an elevated number. And a lot of times that's going to be weight gain, um, depression, anxiety type feelings. You could also have like skin dryness, just dry skin, hair thinning, things like that. When you
Hmm.
have an overactive thyroid or where your TSH is on the lower side, it's the exact opposite. So you might have palpitations, you might have increased weight loss, um, things like that.
Hmm.
So sometimes these are really subclinical where you have normal numbers, but you still don't feel the best. This can also have an impact as far as desire um, and libido, sex drive, all of that. So it plays into a lot of different things, and optimizing that one really involves looking at like your T3, T4. But again, functional medicine is probably going to be one of the best places for that.
Hmm.
Most primary care doctors are not looking at your T3, T4 specifically.
Hmm. Yeah, and those were actually because I did the Everly Well, that's where I knew like to have those added in. And when I did originally, like I brought up thyroid thanks to my doctor. He's like, okay, he tested me for very few. And that's where I go in with my post-it note. And still to this day, it's like, oh, we have you down for this, this, and this. He wants your thyroid panel checked. I'm like, okay, please add this, this, this. Like I add like literally six to 10 more based on what I'm doing, that day or what I'm looking into that day. Um, which yeah, and I feel very fortunate with my doctor. I can add 100 if I wanted to, and it's still like it's still covered. It's like it's the blood draw is the blood draw. So it's literally just a click of a button in the system for them to say check this marker as well.
That's so nice
Hmm.
that they're willing to do that because a lot of places are not like that. A
Mm.
lot of times you will need an order from a provider in order to get those result or whatever labs you're wanting. And yeah, so not always will they give you everything that you're wanting either.
That's
But yeah,
funny.
that's a tricky one. Thyroid's tricky.
I was just gonna say I feel now I'm like probably the annoying patient of his that he's like just whatever she wants, give her what she wants.
Yeah, not necessarily though. Like, um, the challenge is as providers when we order things that we don't know what to do with and it comes back
Mm,
abnormal, now what? And
yeah.
so that's why a lot of times providers are hesitant to add some of these things that, again, if we don't know what to do with it, we should not be ordering it.
Mm-hmm.
Because then what do we do if it comes back abnormal? I don't know what to do with it. And then how am I going to treat you? How am I going to address you? And
Hmm.
so that can be a huge challenge. And that's really our like rule of thumb in medicine. If you don't know what to do with it, don't order it.
Mm. And that makes so much sense because disclosing like my thyroid issues had to do with my antibodies, as you know, like overproducing. And when I went back for after I got on thyroid medication, when I went back to have the blood work done, the antibody tester wasn't even on the order that he put in. And I think in my doctor's mindset, like and I'll use air quotes, I'm worrying about something that I shouldn't be worrying about. And so I think by him not testing it, but I'm like, that's the whole reason I'm here. That's the whole reason I'm on medication in the first place. So why would I not have that tested, right? Like I need to know if the medication is working. I need to know, right? Like, do I not need to be taking this medication? And I knew at that time, like I was starting to feel better, but a big part of the symptoms for me was that weight gain and depression. And that could also be correlated with other things that were going on in my life in that time, and changes that were
Mhm.
happening. So I was feeling like emotionally better, I would say, but I was still having the fatigue, the weight gain was still there, the joint pain was still there, right? Like the just like I want to say more so depression, but like just mood. Like I could tell differences in my mood changes. Um,
Yeah.
so yeah, just interesting, I think. And I've for a long time been saying like I need to get a new doctor, and this I think is a reminder. Like I want a doctor that understands like thyroid antibodies. I want a doctor that falls more into the functional medicine because like you, right?
Mhm.
I'm more about preventative health and not, you know, reactive health, let's say.
Yeah. And I also think we should point out like functional medicine is generally cash pay. Um, and it is also a component of healthism, right? And that
Hmm.
it's not accessible for everyone. Unfortunately, like that is kind of what our medical society has, our insurances and everything has kind of created this
Hmm.
siloed where it's not accessible for everybody, unfortunately. And I would also just like to acknowledge that. Um, but hopefully, like through this information, through this podcast and other resources, you're able to ask for what you want or try and find a provider that better fits what your needs are,
Hmm.
um, too. The other thing I wanted to point out about the TPO, typically you don't necessarily check that repetitively. And
Hmm.
so usually like what that's saying is that it's an autoimmune production of the antibody. And when that's elevated, that is consistent with Hashimoto's thyroiditis. And so um, you were making me feel so smart today. All of these big words. I'm like, wow, I forgot about this shit. And here it just comes on out. But anyway, um, so usually that's more of a confirmation, just saying, yes, we do have Hashimoto's. Okay, great. Um, the medication isn't going to help with the TPO antibodies. What the medication is really helping is your T3, T4, your TSH. But if your inflammation in your body is reduced, that TPO is going to likely come down. And so
Hmm.
inflammation reduction, that's a whole other conversation, but a lot
Hmm.
of that has to do with like diet and our lifestyle and the
Hmm.
things that we're exposed to and environmental shit like the where air that we drink, the air that we breathe, the water that we drink, all of that really is part of that inflammation in our body. The food that we eat, the dairy, the gluten, the soy, those things.
Hmm.
Like we could really go down a rabbit hole with that. Dr. Lowe, I will save that for Dr. Lowe and I will connect you with Dr. Lowe, but
Yeah.
she would be a fabulous resource again for talking about inflammation reduction in the body.
Hmm. Yeah, definitely. And I'd like to put that in the show notes too. So people listening that are wanting to get in contact with her or I'm assuming she is on social, like follow her and her things. Cool.
Absolutely. So, okay, we did thyroid, we did prolactin, testosterone. How did we forget
Hmm.
testosterone? That
Hmm. We
one's
did not.
huge.
It's here. It is on my notes. I was not forgetting that one.
So testosterone and estradiol. We're going to do those two together. So testosterone is a hormone that gives you hyperandrogen symptoms, aka acne, male pattern balding, facial hair, things like that. And the testosterone is very closely linked to PCOS. When that is elevated and you're having irregular cycles or no cycles, that gives you a diagnosis of PCOS, period.
Mm,
Um, so testosterone can be one that gives a lot of problems as far as I would say like confidence and how you feel. Because if dealing with your facial hair all the time can be really frustrating. If you're having a
mhm,
lot of acne, it can be really frustrating. The other component of that is testosterone can be really low and undetectable. And this, I would love to point out a couple things, especially in the work that you do with sex therapy and sex coaching. A lot of times I see patients that have low testosterone, and my first question is, how is your energy and how is your desire?
mhm,
And a lot of times they're like, it's trash. How did
mhm,
you know? Is basically what they look at me like, I don't know, I don't understand how you even knew that. I'm like,
mhm,
well, when your testosterone is low, that directly impacts your energy levels, that directly impacts your sexual desire. Testosterone is something that women also produce. It is not just a man's hormone.
mhm.
And so with the testosterone, if you have low, less than 10 testosterone, do not try this at home without medical support, but DHEA, um, the supplement DHEA, will help with your testosterone. And so, if you do have really low, undetectable testosterone, that might be something to see how you feel with that. But you have to be careful because if you take DHEA and you take too much of it, now you're going to start getting your facial hair, you're getting the
Oh,
acne, you're going to get those hyperandrogen symptoms. So, it's this fine balance of getting enough to feel better, but not doing too much.
mm, mhm,
High testosterone. This is another one. One of my good friends who is a bodybuilding coach. We talk about this all the time, but in
mm,
functional medicine, sometimes that testosterone can be pushed too high for women.
mhm,
Greater than 100 is really too high for women. The sweet
mhm,
spot is going to be less than 100 if you're taking supplemental testosterone, um, which comes in creams, pellets, um, technically injectables, but most people are doing more like creams and pellets for women.
mhm,
And so you have to be very careful where you're not going too high because you can get clitoromegaly, which is enlarged clitoris. You can have voice changes. So this is another one where we have to be very careful about how we're dealing with it,
mhm,
but one that can definitely be tested and optimized for overall health too.
mhm. And what is the baseline? Like, what do we want to shoot for? I thought you said
Less
less
than
than,
50
okay,
for somebody who's untreated, but
okay,
really like between 10 and 50 on your testosterone total free.
okay. And
Because
that's,
there's different
so you
tests too.
have, I was gonna say, because you have free T3, free T4, and testosterone are all three separate markers that you would have drawn.
Yep.
Okay. And this,
Yeah. And
what
the
we're speaking
T3,
about
T4,
specifically is
those are
testosterone.
thyroid. Yeah. T3, T4 are thyroid. That's not at all related to testosterone.
Oh, didn't know. Okay. So, okay. Thank you for that. For whatever reason, I saw the T and I was like, okay, testosterone, free T. So,
Yeah. Nope.
I
Those are thyroid.
learned. Okay. Perfect. Okay, so testosterone, this whole last 5 minutes that we were just talking about, that is based on the hormone testosterone and only that hormone.
Yeah.
Okay. So less than
Yep.
10, there's concern, and baseline for women
Well,
10 to 50.
yeah. And there's not necessarily concern less than 10, but if you're symptomatic and you're not feeling well less than 10, try some
Mm-hmm.
DHEA,
Mm-hmm. Okay.
but don't do too much.
Okay.
Do like what I recommend is 25 milligrams up to 3 times a day, but just
Oh.
titrate based on how you feel is really what I use for my North Star for my patients. Like, how do you feel?
Mm-hmm.
If you feel great, great. Try a little more. If you don't feel any better, go back.
Mm-hmm. And if I can take a moment to kind of plug this in too, of like whether you're doing hormone testing or not, like truly take a moment in your day, a couple times a day, to check in and see how you're feeling. Because I think I just recently started a new type of therapy, and I was going through the questionnaire, and it's asked me, right, all the PHQ-9, the GAD, like all the questionnaires, and I'm like, okay, in the past 2 weeks, like how have these actually applied? In the past 30 days, have these actually applied? And I'm more, and I'm that type A person, so I like take those things very seriously and want to answer them correctly, but and often probably overthink them. But again, that just reminded me of like, okay, how often am I actually checking in with myself to see how I'm feeling?
Yeah. And so often, I mean, this is one of the things you and I think, have worked really hard on. But a lot of times as women, like we kind of carry the world on our plate and we forget about ourselves. We're not checking in with ourselves. It's not taught to us many
Hmm.
times. And so this is something we have to go back and relearn. Like, how am I feeling? Where am I at? What is happening?
Hmm.
And creating space in our lives to do that.
Yeah. Yeah. And it's hard. It is hard to come up with a right like a regimen, a routine into which you are checking in and you are doing all of the self-care things, right, that people recommend. It to me it sometimes feels like a part-time job. Like, okay, I've done my
It
journaling,
is.
I've done my meditating, I'm drinking my water, I'm getting the sleep, I'm doing all the things. I'm like, shit, man, like
Yep.
I could spend 2 hours a morning on just checking all my boxes.
Um, my morning routine could easily be 4 hours,
Yeah.
easily in a heartbeat. And it's like, so when am I supposed to, like, go to work and
Work.
do a
Yeah.
job? Like, I don't know.
Yeah.
I'm not. That's reality. I'm not.
Yeah, we're not meant to do those
But
things.
yeah, the other one, just to touch base as far as estradiol. So this is also one that is part of your menstrual cycle. And estrogen is going to vary throughout your menstrual cycle as well. It peaks around ovulation and then it peaks again in your luteal phase. The biggest thing about this is like estradiol really doesn't mean a whole lot.
Hmm.
But if it's low, then, and oh, I'm going to remind me to tell you about birth control in just a second. But if it's low, can also have some impacts as far as low desire. So if it's undetectable as well, or on that lower side, it can also have some impacts there. And estrogen support is very common now, especially when we're menopausal. Highly recommending looking into that for optimal health and
Hmm.
optimal, um, just like quality of life, right? Like
Hmm.
just to feel good. The other thing is estrogen is really important for cardiovascular health, brain health, and bone health. And so it's definitely one to kind of just be aware of, but it does vary throughout your cycle. Too low doesn't mean anything, too high doesn't mean anything. Ask questions to your provider.
Hmm. And if we have a moment, because I think estrogen, a lot of my clients are on estrogen, and I remember at the retreat we had conversations around bioidenticals versus not. Could you just touch on that? Like what does a bioidentical mean? And then what is the other option if you're not doing a bioidentical?
Yeah. So you have estrase, which is going to be like your pharmaceutical made estrogen. Bioidentical is going to be similar to like your natural production of hormone. Those are generally going to come from your compounding pharmacies. Those are going to be more expensive, less readily accessible.
Mhm.
As far as the your doggy, I could hear him.
Could you hear him? I know. I'm
I
like
could hear
trying to
him
distract
just that
him.
time though.
Oh, good. Okay.
I didn't
He's,
hear him at all
yeah.
before, but I just heard that. I'm like, oh,
He
listen
is
to him.
chomping on this bone, and I'm like, get out of here, dude.
Um, but yeah, as far as like bioidentical versus, just estrogen pills, patches, it really depends on what works best for you.
Hmm.
Um, I don't know that there's necessarily any specifics. If I was to do it, I would do bioidentical because I like more natural stuff, but
Hmm.
does it necessarily matter? I don't know.
Yeah. And so, yeah, neither are wrong per se. Like, do what is affordable and again, best for you.
Yeah.
Okay.
Yeah.
Thank you for answering that.
Of course. Trying to think if there's anything else I wanted to say about estrogen. Um, mhm. If I think of it, I'll let you know.
Okay. I think that covers it. We wanted to maybe lightly touch on cortisol or DHEAS or
Yeah. So let's touch on those. I don't know if you've had her on your podcast, but I did a whole episode on cortisol
mm,
with, I want to say it was like Christine. I'd have to double check and I can send you the podcast, but
hmm
cortisol is a very interesting one. I'm not very familiar with testing it. I have had some testing myself,
hmm
but I don't do testing for patients, so I'm not super familiar with it. But um, best done saliva or urine.
mm,
So you can do it through urine with like a Dutch test, but it does change throughout the day. So it's going to
hmm
peak in the morning. Um, a lot of things, stress really has an impact as far as your cortisol levels.
hmm
Um, and so this is kind of an interesting one. A lot of times it's going to be more of your functional medicine. I don't know that many traditional like family practice providers are familiar with it.
hmm
In my office, we do order it sometimes when we have extremely high testosterone and some other things that there is concern for maybe an adrenal cancer
mm,
or some sort of tumor producing that, an exogenous production of the cortisol. But other than that, that's all I'm really testing it for.
hmm
So yeah, that's kind of an interesting one. Um, Go check out that podcast or have Christine on your podcast if you haven't had her yet to talk about cortisol, because that was a really good conversation actually.
Yeah. And Jordan is the host of the Vaginas, Vulvas, and Vibrators podcast. And she's like me, have been podcasting for many, many years. So definitely check out her podcast. She has a lot of good episodes on there.
Yeah.
You put out weekly-ish episodes, sometimes more at one point. So it's yeah, there's a definitely a uh, uh, diversity of episodes to check out on your
Yeah.
podcast.
Yeah. The other one just of mention is DHEAS or
Mhm,
DHEA sulfate. This again is one where like sometimes if your testosterone is not elevated, your DHEAS might still be elevated and can it's a precursor ultimately to your thyroid or to your testosterone.
mhm,
And so not commonly tested for
mhm,
unless we're really looking for more like exogenous forms of testosterone, or if we are concerned about PCOS and testosterone is normal. But for the most part, that's actually not one that I test very often either.
mhm,
But it is something just to be aware of that some providers do look at for more of like the PCOS standpoint.
mhm. Awesome. And I
Yeah.
did want to plug for people that are in Michigan. I know I have a lot of local people that listen to the show. The clinician doctor that I recommend for people to go to is Dr. Jody Robinson. She works out of Dearborn OBGYN. She is a gynecologist, I think, by trade, but also does holistic medicine, functional medicine, like very forward thinking, if you will, and very well versed in hormone testing and things like that. So if somebody's listening to this, like, where do I go? Who do I seek out? Like, who's going to hear me? Jody Robinson is who I would recommend for people to go to.
I love that. I love that. For those of you that are not local to Michigan, um, going back to Dr. Lowe, I have not
Mhm.
worked with Dr. Lowe, but Dr. Lowe does do like nationwide, I believe. And so that would be another really great like resource. She is going to be cash pay, I believe. She's a
Mhm.
naturopathic doctor. So not an MD, not a DO, but a naturopathic doctor.
Okay. Yeah, we'll definitely link her in the notes for people.
Yeah. Yeah. She's a great resource. So, what else was on the list? Did we cover everything?
I think, yeah, I was just looking it over.
Yeah.
I think that was everything. Yeah, just doing a double check. I truly think that was everything. And I know this is a little bit longer of an episode than usual, but just such a great resource. I think we really covered a lot of ground here for people.
We did a lot of information. This is probably one that you're gonna have to like listen to in bite-sized pieces because
Hmm
it's pretty sciencey, pretty in depth.
Yeah.
But yeah, if you have any questions, like this is the shit I love to talk about, slide in my DMs.
hmm
I really enjoy hormones and things, and it's not straightforward. Like
Yeah.
it's very tricky. There was one more thing I wanted to talk about, birth control.
Sure. Oh, yes, yes, yes.
So, um, I've done some episodes on birth control. I am not shaming birth control. Birth control is great for a lot of people for a lot of different reasons. But one thing to be aware of, if you are on birth control, especially for a long period of time, it is not uncommon to have low FSH, low estradiol, because what it is doing is it's suppressing that pathway. So that
Mhm.
is very normal to see that. Um, there's one other hormone test that we could talk about. It's sex hormone binding globulin, SBHG. That is something else that some people test. Limited information that I have about that, but
Mhm.
that generally goes a little bit higher when you're on birth control as well.
Mm. Okay. Yeah, I
So yeah.
know I've done episodes on birth control. You've got plenty of episodes on birth control. If somebody's listening that's considering getting off or getting off birth control, not getting off, it's actually, but yes, getting off birth control, or you're on birth control and you're not liking it, or many things. You just got off of birth control. This was the rabbit hole that I went down when I was making this decision back in 2020. So it's, yeah, there's definitely some good research out there. In the Flow by Elisa Vide is a book I recommend for
Mm,
people. She does a lot
yes.
of hormone talking conversations in that book. I feel like there was another one, another hormone book that I give people that I
I mean, her
cannot.
woman code was really good too.
Yeah,
I think In the Flow is was one of my favorites for
me
understanding more of
too.
just about the menstrual cycle. Even though I work in the menstrual cycle,
Hmm.
that really helps me understand for like more holistically about the menstrual cycle.
Hmm.
So if you're curious about your menstrual cycle, wonderful resource there as well.
Yeah, wonderful. All
Cool.
right, Jordan, this a
Thank you.
wrap?
All right. We'll wrap it up. I won't, yeah.
Oh, yes.
Oh, Lord.
I love it. This was so helpful. Thank you again so much for coming on, sharing your expertise. Again, just super impressed with just how easily this information comes to you. Again, I know it's daily conversations you're having with people, so thank you so much.
Yeah. Thank you for having me back. I appreciate it.
Yes, and follow Jordan at Jordan Donnell, right, on Instagram.
Yep.
Follow the podcast, Vaginas, Vulvas, Vibrators. It's great,
Yeah,
and
check it out.
sure you'll be on again someday.
Yes. Thanks,
Of
Rachel.
course.